Good morning. Thank you, Terry and Tina, for inviting me to speak. I have no disclosures. So cancer in pediatrics continues to be a leading cause of death, second only to trauma in children aged 5 to 14. And malignancies in the head and neck account for approximately 5% of all these childhood cancers. The most common malignant tumors that we see in the head and neck are lymphoma, followed by rhabdomyosarcoma and nasopharyngeal carcinoma. Less commonly, we'll see tumors of the thyroid gland, salivary glands, and other sarcomas. What I'd like to do over the next 30 minutes is we'll look in detail at the imaging findings for these common malignant tumors, and then more quickly go through the less common tumors. And I'd like to take a case-based approach which will allow us to look at both typical and atypical presentations for these lesions. We're also going to keep in mind that the majority of head and neck masses in children are inflammatory, and I'll try to point out examples where there may be overlap between benign and malignant disease. So the first case is a 7-year-old boy who came to the emergency room for headaches, and he had a head CT that showed a normal brain, but this large neck mass was found. And even before we do dedicated imaging of the neck, we can get a lot of information just from this non-contrast head CT. We can see that the lesion is homogeneous in attenuation and that the styloid process is pushed laterally, but there's no widening of the stylomandibular gap. It looks like it's centered on the parapharyngeal space, but if you play with the windows, you can appreciate that the parapharyngeal fat is displaced laterally and only partially effaced, telling you that the lesion is arising from the pharyngeal mucosal space. And on the bone windows, you can appreciate that the lesion abuts the anterior arch of C1, but there's no osseous erosion or remodeling. On MRI, you can see that the lesion is intermediate signal on T2. It's involving the nasopharynx and oropharynx. There's no intracranial or skull base extension. On the pre-contrast T1, you can again see the parapharyngeal fat displaced laterally, and it has homogeneous enhancement. On the post-contrast images, there's invasion of the prevertebral musculature. The lesion has restricted diffusion. It's FDG avid. This turned out to be a Burkitt lymphoma. So Burkitt lymphoma is a subtype of non-Hodgkin lymphoma. These are malignancies of the lympho-reticular system, and in the head and neck, we divide them into 3 types based on location. Nodal, non-nodal lymphatic, arising from the palatine or lingual tonsils or adenoids, or extralymphatic, which can occur almost anywhere in the head and neck. These extralymphatic lymphomas can be infiltrative or focal. Here's a 16-year-old boy with a non-Hodgkin lymphoma, and you can see enlarged jugular chain nodes bilaterally. There's enlarged submental and submandibular nodes and bulky enlargement of the adenoids. So in this patient, you might consider acute EBV infection in the differential diagnosis. This is certainly a good age for that. But in that scenario, typically the adenoids are more edematous in appearance and have a striped areas of lower attenuation. And this anterior or level 1 adenopathy is uncommon in acute EBV infection. The WHO classification has over 30 subtypes of non-Hodgkin lymphoma, with the B cell types being more common overall. In children, the most common subtypes are Burkitt, diffuse large B cell, lymphoblastic B or T cell, and anaplastic large cell. Here's a 9-year-old boy with a lymphoblastic T cell non-Hodgkin lymphoma. You can see rounded, homogeneous, moderately enlarged lymph nodes bilaterally, slightly greater than you expect for a benign reactive disease. Non-Hodgkin lymphoma is more common in boys compared to girls and has a peak age in pediatrics of 7 to 11. We see an increased incidence in immunocompromised patients, be that from congenital or acquired causes. Here's a 15-year-old boy. This is another Burkitt lymphoma. You can see the supraclavicular lobulated mass. It's made up of a conglomeration of enlarged lymph nodes. It's sort of homogeneous and isointense to muscle on T1. And this one actually has a peripheral pattern of enhancement. So in this lesion, it's a little bit different than the Burkitt lymphoma that we already looked at. It's more hyperintense on T2 and has a different enhancement pattern. And just like we're used to looking at tumors elsewhere in the brain and everywhere else in the body, sometimes the same tumor type in different patients can look different. A little bit more about Burkitt lymphoma, since it's one of the most common non-Hodgkin lymphomas that we see in pediatrics. There's 3 types. Endemic that is seen in Africa more, sporadic seen more frequently in North America, and then the immunodeficiency type, those patients tend to present with adenopathy. All patients with Burkitt lymphoma will have this abnormal translocation or a dysregulation of the c-Myc gene, which encodes for a protein that's involved in cell regulation. And it's also been shown that previous EBV exposure is implicated in the development of these tumors, especially in the endemic type. And it's thought that the EBV virus actually acts as a B-cell mitogen, which increases the population of lymphocytes, which are then susceptible to developing this genetic abnormality. Here's a 3-year-old boy with a Burkitt lymphoma involving the mandible. You can see invasion of the mandibular ramus, lytic changes on CT, and the lesion looks cellular on the diffusion-weighted images. Hodgkin lymphoma is less common than non-Hodgkin lymphoma, and in pediatrics, we tend to see it in adolescents. It's rarely extranodal as opposed to the non-Hodgkin lymphoma, and it also has an association with previous EBV exposure. At pathology, there's this binucleated Reed-Sternberg cell, but most of the tumor bulk is reactive inflammatory cells. The most common clinical presentation for Hodgkin lymphoma in an adolescent is an enlarging unilateral neck mass. So in this 14-year-old boy, we can see this large neck mass that's made up of a conglomeration of enlarged lymph nodes diffusely throughout the left neck. Here's a 7-year-old boy who had the same clinical and radiology presentation, multiple enlarged lymph nodes diffusely throughout the left neck. And there's also mediastinal lymph nodes shown on the PET imaging. So neck adenopathy is a common presentation for both of these types of lymphoma, and imaging cannot really distinguish between the two. There's a few clues that may help you consider one versus the other. Non-Hodgkin is more common overall than Hodgkin lymphoma. Hodgkin lymphoma is rarely extranodal, and in all comers, if you look at pediatrics and adults, Hodgkin presents at a younger age. But Hodgkin lymphoma is really rare under the age of 10. It's also interesting, some patients with lymphoma will present only with cervical lymphadenopathy, but many patients will have additional lymphadenopathy in the chest, abdomen, and pelvis. The patients with Hodgkin's lymphoma are slightly more likely to have that additional adenopathy in the chest, and the patient with the non-Hodgkin lymphoma is slightly more likely to have that additional adenopathy in the abdomen or pelvis. So the treatment depends on the stage. The patients will either get chemotherapy, radiation, or combined modality treatment, and then bone marrow transplant for a recurrent or refractory disease. So here's our original patient, our patient with a Burkitt lymphoma. He had this single lesion with no disease elsewhere, was treated with chemotherapy, and at 1-year follow-up, there's no residual tumor. Okay, moving on to the next tumor type. This case is a 10-year-old boy who presented to the emergency room with neck pain and no history of trauma. On his post-contrast neck CT, you can appreciate at the C6, C7 level, normal relationship of the esophagus and trachea. Just inferior to that, there's this abnormal prevertebral mass displacing the trachea and esophagus anteriorly, and it also looks like there's a little bit of abnormal attenuation within the spinal canal. On the bone windows, there's a subtle compression deformity of the T1 vertebral body. On MRI, on this post-contrast T1 weighted image, you can appreciate the prevertebral and paraspinal mass. It's very infiltrative. The lateral borders of the lesion are difficult to define. There's tumor in the spinal canal surrounding the thecal sac, completely effacing the subarachnoid space. On the sagittal post-contrast T1 weighted image, you can see the prevertebral, vertebral, and epidural components of the lesion, compressing the spinal cord, and there's cord edema on the T2 weighted image. This was a rhabdomyosarcoma. So rhabdomyosarcoma is the most common soft tissue sarcoma in pediatrics, and 35% of these arise from the head and neck. There's an increased incidence in patients with a P53 tumor suppressor gene mutation, and there's also an increased incidence in patients with Noonan, NF1, Li-Fraumeni, and Beckwith-Wiedemann syndrome, although most of the time we see this tumor in children who are otherwise healthy. At pathology, these tumors have their origin in primitive mesenchymal cells that are destined to form skeletal muscle cells. And there's 2 histologic subtypes that we see most commonly in pediatrics, embryonal and alveolar. Some patients with the embryonal form will have an abnormal deletion on chromosome 11. The embryonal type occurs more often in younger patients and has a better prognosis. The alveolar type tends to occur in older patients and has a predilection for the extremities. 75% of these patients will have this abnormal gene fusion or translocation, but the patients without this gene abnormality actually have a better prognosis similar to that of the embryonal type. In the head and neck, we divide rhabdomyosarcoma into 3 types based on location: orbit, parameningeal, and non-orbit, non-parameningeal. The parameningeal are those locations close to the brain, and they include the masticator space, the ear, sinus, nasopharynx, but also the pterygopalatine fossa and the parapharyngeal space. The most common subsites overall are orbit and masticator space. Here's a 13-year-old boy with a soft tissue mass along the inferior orbital rim, rhabdomyosarcoma. And here's a 10-year-old boy with the right masticator space rhabdomyosarcoma. You can see tumor on both sides of the mandible with invasion of the mandibular ramus. There's no intracranial extension. So once you see a tumor or a mass in one of those parameningeal locations that you think might be a rhabdomyosarcoma, it's important to look for that intracranial extension. So here's 3 different cases just showing that to varying degrees. In this 18-month-old boy, you can see on the T2 weighted image a big lobular masticator space rhabdomyosarcoma with extension towards the cavernous sinus through foramen ovale. In this 12-year-old girl, another left masticator space rhabdomyosarcoma. There's abnormal enhancement of the left foramen ovale, and you can compare that to the normal exiting V3 on the right. She actually presented with trigeminal neuralgia, and you can appreciate the widening of the mandibular canal for the inferior alveolar nerve here on the left. And here's an 18-year-old boy with another big left masticator space rhabdomyosarcoma with big lobular extension intracranially via widened foramen ovale. On the coronal image, you can also see that there was invasion of the pterygopalatine fossa with tumor extending into the orbit via the inferior orbital fissure. So this slide also nicely shows the wide age range that we see for rhabdomyosarcoma. This tumor has an incidence that peaks in patients under the age of 6 and then again in adolescents. Here's a case. This is a 14-year-old boy who went into his pediatrician in rural Kentucky for face pain, was treated for sinusitis. A couple of days later, he went to the dentist for loose teeth, and the dentist started to drain what he thought was an abscess, and he realized he was getting into something more serious, and he referred the patient to an oral surgeon. So in that time period when the patient was waiting for that oral surgery appointment, the family became overwhelmed with the symptoms, and they presented to the emergency room. And this was the first film that was obtained because of that dental history. And I actually have to give my colleague credit because he didn't have any of that history, but he noted that there was more lucency over the left maxilla compared to the right, concerning for an aggressive process. And in this patient, you can see a big maxillary sinus rhabdomyosarcoma extending into and filling the nasal cavity and nasopharynx. It's bright on T2, homogeneous on T1, has heterogeneous contrast enhancement. And here we have another one of those parameningeal locations. So we're going to look for the intracranial extension, which we do not have in this case, but you can see a superior displacement of the orbit. And it looks cellular on the DWI images. One of the fascinating things about rhabdomyosarcoma is all the different things that it can do to bone. So in this single case, this maxillary sinus rhabdomyosarcoma, we have complete resorption of the lateral wall of the nasal cavity, but a remodeling of the orbital floor. If you look at the axial images, there's an amputated appearance of the maxilla, this disorganized appearance of the bone fragments. Some of this might be postoperative from that dental procedure. And if we look at the MRI, we can see this aggressive skull base invasion into the sellar floor, but the medial margin of the tumor looks well marginated. Here's another rhabdomyosarcoma of the masticator space demonstrating yet another pattern of bone involvement. Here we have a moth-eaten permeative appearance of the sphenoid skull base. Big intracranial extension with tumor extending along the cisternal portion of the fifth cranial nerve. There's tumor in the sinus and in the orbit. And you can see its effect on the nasopharynx is causing eustachian tube dysfunction with fluid in the mastoid air cells. And it looks bright on the DWI images. So the treatment. The patients do best if they can have complete resection of the tumor, because those patients can get an adjuvant chemotherapy that's relatively non-toxic. The non-resectable tumors are treated with radiation and chemotherapy. The exception to that rule is the lesions in the orbit. These patients actually have a better outcome if they're treated non-surgically. So here's an example of that. Here's an 11-year-old boy with this seemingly superficial mass in the superior anterior orbit surrounded along the globe. He was treated non-surgically, and he's still coming back as a young adult for his follow-up. His orbital imaging is completely normal. The only way you can see that the tumor was there is if you look back at the original studies. Okay, moving on to the next tumor type. This is another patient whose story begins with a trip to the emergency room prompting a CT scan. Here's a 14-year-old boy with neck swelling for 1 month, getting worse on antibiotics. On his post-contrast CT, you can see this mass-like enlargement of the adenoids filling the nasopharynx and extending into the nasal cavity. A little bit lower down, you can appreciate the enlarged retropharyngeal lymph nodes and jugular chain nodes bilaterally more on the right. There's a little bit of retropharyngeal nasopharyngeal fluid. And you can also appreciate the medial positioning of the internal carotid artery, which may become important for the surgeon, depending on where they're going to do their biopsy. MRI showed pretty much the same findings. The nasopharynx mass looks pretty homogeneous on T1. On T2, there was more heterogeneity, and there was more hypointensity posterior laterally in the nasopharynx, suggesting that the mass was possibly arising from that region. The post-contrast T1 weighted images again show you the retropharyngeal and jugular chain adenopathy. And the mass in the nasopharynx looked dark on the ADC maps. And I included a picture from a normal patient just showing that the normal adenoids can look relatively bright, a little bit bright on DWI, making it hard to look at the diffusion weighted images in the nasopharynx. This was a nasopharyngeal carcinoma. And one of the pertinent negatives in this case is that there was no skull base extension, and the clivus looked normal on this T1 weighted image. Nasopharyngeal carcinoma is a mucosal tumor of the lateral pharyngeal recess, or the fossa of Rosemuller. It's rare in pediatrics, but when it does occur, it tends to occur in adolescents, and they present with nosebleed, hearing loss, or nasal obstruction. And greater than 90% of these patients will have nodal disease at presentation. At pathology, there's two subtypes, keratinizing and non-keratinizing, and the non-keratinizing is further subdivided into differentiated or undifferentiated. The most common that we'll see in pediatrics is the undifferentiated non-keratinizing, and these types have an association with previous EBV infection. There's a nice article, a series from Hilda Stanbuck and her group at Sloan Kettering. They looked at 11 pediatric patients with nasopharyngeal carcinoma and describing the imaging findings. And finding nasopharyngeal carcinoma early in pediatrics can be challenging because of the adenoid enlargement that we see in the healthy population. But for nasopharyngeal carcinoma, what we're looking for is an asymmetric enlargement of those adenoids. In their series, all of their patients had fluid in the mastoid air cells. All of them had adenopathy. Many of them had skull base invasion. And they described a finding of a widening of the petroclival fissure, which we'll go over. Here's a 13-year-old boy that illustrates all of those findings that were nicely laid out in that article. He has a lateral nasopharyngeal mass posteriorly on the right. There's fluid in the mastoid air cells from eustachian tube dysfunction. A little bit lower down, we can see these retropharyngeal lymph nodes. They're not huge, but they're abnormal because they're necrotic. There's a cystic jugular chain node. And if we look at the CT images, we can appreciate the skull base invasion with lytic changes medial to foramen ovale. And here's that widening of the petroclival fissure. Here's the abnormal petroclival fissure on the right. Compare it to the normal petroclival fissure on the left. And in this case, there was actually intracranial extension with tumor extending up into the cavernous sinus around the internal carotid artery. So we saw some cases of intracranial extension with rhabdomyosarcoma sarcoma. In nasopharyngeal carcinoma, the intracranial extension is a little bit different and that it's more medial. There's a fascial layer, the middle layer of the deep cervical fascia, that separates the pharyngeomucosal space from the parapharyngeal space, and it inserts at the skull base just lateral to foramen lacerum and medial to foramen ovale. So what you'll see in these tumor types is that the tumor tends to be directed up through foramen lacerum around the internal carotid artery. So we're seeing that nicely in this case with tumor next to and around the internal carotid artery, and the skull base erosion is medial to foramen ovale. It's important to look for that skull base invasion because that'll upstage these patients to T3 disease, and we saw it on CT, we saw the lytic changes. In the same 13-year-old boy, what we're looking for on MRI is a change in the signal. So if you look at the clivus just to the right of the midline, there's abnormal low signal, and you can see preservation of normal signal in the clivus to the left of midline. On the T2 weighted image, we can see abnormal T2 prolongation in the Bassi occiput here to the right of midline compared to the normal signal to the left of midline. Here's a 12-year-old girl. She came in for a screening brain MRI for headaches. She had this unexpected nasopharyngeal carcinoma that's located a little bit more anterior and superior in the nasopharynx than the cases I've already shown you. In this case, the skull base invasion is into the pterygoid process here on the right, and you can compare that to the normal pterygoid process here on the left. You can see the lytic changes anteriorly in the central skull base, but you can also see sclerotic changes in the Bassi occiput more posteriorly in the clivus. So with nasopharyngeal carcinoma and skull base invasion, you can get sclerotic or lytic changes in the skull base. For the treatment, these tumors are very radiosensitive, and depending on the stage, the patients will get radiation only or radiation and chemotherapy. Here's our 13-year-old boy who had the intracranial extension. He was treated with radiation and chemotherapy. And this case is still sort of fresh, but at 8 months out, it looks like he's having a very good treatment response. So thyroid carcinoma, depending on what series you read, thyroid carcinoma has an incidence that's similar to or slightly less than nasopharyngeal carcinoma in pediatrics. What's important to remember is a nodule in a child is more likely to be malignant. An incidentally discovered thyroid nodule in a child has a 26% chance of malignancy versus only a 5% in an adult. And the breakdown of the differentiated thyroid carcinoma is similar to that what we see in adults. More of them are papillary type compared to the follicular. If you see a medullary carcinoma in a child, it's almost always in association with one of these autosomal dominant multiple endocrine neoplasia syndromes type 2. Often they have nodal disease at presentation, and these nodes can be cystic or solid, and you may see calcifications in the tumor or in the nodes, especially in the papillary subtype. Here's a 7-year-old boy. This is a papillary carcinoma of the left lobe of the thyroid gland, and you can see this hyperechoic mass and an abnormal node posterior to it. Here's that same patient. He had non-contrast CT in anticipation of I-131 therapy. The mass itself was actually seen better on ultrasound, but you can appreciate this abnormal visceral node just inferior to the left lobe of the thyroid, and it has faint calcifications within it. Here's a 13-year-old boy with an aggressive-looking lesion arising from the left lobe of the thyroid gland. You can appreciate the claw sign. This was a follicular carcinoma. Juvenile nasal angiofibroma is a benign lesion but locally aggressive. We see it in males, and they present with nosebleed or nasal obstruction, and it has its origin in this very specific location, the posterior lateral nasal cavity at the sphenopalatine foramen. So in this 13-year-old boy, you can see this heterogeneous mass filling the nasal cavity and nasopharynx bilaterally. You can appreciate extension into the pterygopalatine fossa here on the right, and you can compare that to the preservation of the fat seen here on the normal left side. The same patient, looking at the coronal image, you can get a coronal view of the pterygopalatine fossa with tumor pushing up towards but not into the inferior orbital fissure, and there's skull-base destruction centrally on the bone windows. At pathology, these tumors are very vascular and often treated with embolization preoperatively. And it's thought that androgens play a role in the biology explaining why we see these lesions exclusively in males. There's pterygopalatine fossa extension in 90%, and you can have bone remodeling or destruction. Neuroblastoma is unusual to be primarily seen in the neck. It's most commonly arises in the retroperitoneum or the adrenal gland. It can occur, though, anywhere along that sympathetic chain from the neck to the pelvis. And in the neck, that sympathetic chain is just outside of the carotid sheath, posteriorly and medial to those vessels. So that's where you'll see these tumors. So in this 6-month-old girl with a cervical neuroblastoma, you can appreciate this large mass posterior to the carotid sheath pushing those vessels anteriorly and laterally. We see calcifications less frequently in the cervical neuroblastoma compared to the abdominal neuroblastoma, but this case happens to have a calcification within it laterally. In the same case on MRI, the lesion is homogeneous on T1, it's bright on T2, and you can see a calcification in the lateral aspect of the mass, and it's bright on DWI. More often what we see in neuroblastoma in the head and neck is metastatic disease, and I wanted to show this case because the findings are so symmetric and so diffuse that they almost lose their conspicuity depending on what imaging study you look at. Here's an 8-month-old boy with metastatic neuroblastoma, and the findings are best seen on the post-contrast T1 weighted images, where you can appreciate enlargement of the bones surrounding the orbits in the middle cranial fossa. There's abnormal enhancement lining those osseous structures. On the coronal post-contrast T1, you can appreciate the dural and or extradural enhancement lining the middle cranial fossa bilaterally. On T2, the bones look a little bit expanded, but it's not as conspicuously seen as on the T1 weighted images, and they're actually a little bit bright on DWI. This boy actually presented to the emergency room 2 days prior before the diagnosis of metastatic neuroblastoma was known, and his request said, fall from 18 feet, bruising under both eyes. So he had that classical clinical presentation of raccoon eyes in the setting of metastatic neuroblastoma to the skull base. And his head CT was read as negative for trauma, which was true, but if you look back, you can appreciate abnormal expansion of those bones along the orbits in middle cranial fossa with the abnormal periosteal reaction, and you can especially appreciate the of periosteal reaction if you look at the mandibular rami, where it looks aggressive on both sides. Other sarcomas are a diverse category making up to 5% of head and neck malignancies. Most commonly, we'll see osteosarcoma and Ewing sarcoma, but we can see these other tumor types. Here's an 11-year-old girl with an ethmoid sinus chondrosarcoma. You can see the ring and arc calcifications that are consistent with chondroid tumor matrix. Here's a classic osteosarcoma of the mandible. We have a cloud-like mass on plain film, lytic and sclerotic changes in the body of the mandible on CT with aggressive periosteal reaction. And on the soft tissue windows, you can appreciate the osteoid tumor matrix. Here's a Ewing sarcoma. So it's amazing how in the course of the day you can have an imaging study for the tiniest irregularity that the pediatrician or the parent will palpate in the skull or scalp, and then other times you'll get a case like this. Here's this profound lesion centered on the frontal skull. There's a small epidural component, a large exophytic component extending into the scalp. It's sort of intermediate signal on T2, has homogeneous contrast enhancement, is bright on the DWI images, and on the CT you can appreciate this lamellated, aggressive pericranial reaction. The last entity I'll show you is granulocytic sarcoma. These are soft tissue collections of leukemic cells that occur outside of the bone marrow. They can be the initial presentation in pediatrics for leukemia, but most often it occurs in refractory disease or later in the disease course, and it's usually seen in the setting of AML. Here's a 10-year-old girl. She was diagnosed with AML 2.5 years before this image, and she presented with a palpable mass in her nasolabial fold, and you can see this premaxillary soft tissue mass. Here's a 14-year-old boy. He was diagnosed with AML at age 4, had 3 years of chemotherapy, was doing well off therapy when he presented with this palpable mass in his cheek. This turned out to be a recurrence of his AML in the form of a granulocytic sarcoma. So in summary, the most common malignant tumors that we see in pediatrics are lymphoma, rhabdomyosarcoma, and nasopharyngeal carcinoma, followed closely by thyroid cancer. EBV, previous exposure to EBV is implicated in the development of Burkitt, Hodgkin, and nasopharyngeal carcinoma. All the malignant tumors that we looked at were bright on DWI and had low ADC values. There's a lot in the literature now on quantitative ADC values to try to distinguish between all the different tumor types, especially in the adult literature. And I think where we're at right now is that you can look at the diffusion-weighted images as just another tool in addition to all of your other imaging findings. Distinguishing benign from malignant adenopathy is usually straightforward. Sometimes it comes up in the setting of lymphoma. You can look at the clinical history or other signs of infection to diagnose benign disease. For malignant disease, you might look for adenopathy elsewhere. Luckily for the clinician, this is a common scenario that they're very comfortable with, and they will either work the patient up right away for malignancy, or if they think it's benign, they'll place the child on antibiotics just to make sure that those big benign nodes go away. And then finally, I was amazed at how many of these patients had their initial presentation in the emergency room. And I think that poses a challenge for us as radiologists because the ERs tend to be biggest in the evening when our staff is the thinnest, and these cases tend to be very work and time intensive.